our hour together today. So before we get started with anything else, I want to let folks know a little bit about the technology that we're using today. There are a little less than 100 of you on the line and growing, so we're going to take questions via typed written questions today. All of you are on a global mute, so you can feel free to talk to one another if there are other people in the room. And type your questions via the questions pane on your GoToWebinar control panel. We probably will hold some time at the end of the presentation today to take those questions. And so if you could hold off on questions till the end of the presentation, that would be great. Just one second here where I think we're going to get our slides going. Okay, there we go. Okay, I think we're having some technical problems with the slides, so just give us one moment to advance the forward. Never mind, looks like we got it. All right, so I'm going to quickly cover our agenda for the webinar today. My name is Kate. I'm a program coordinator with the Institute. I'm going to tell you a little bit about the Institute to start us off, and then I'm going to hand things over to a couple of representatives from the Oregon Health Authority, and they are going to talk about the Patient-Centered Primary Care Home Program, how the PCPCH standards were developed. They're going to talk about some important updates related to the 2013 standards, and then we're going to, like I said, hold some time for your questions and then have a short survey at the end. One thing I do want to know, because there are 100 of you and growing on the line, we may not get to all of your questions today. There'll be an opportunity for you to leave additional questions in the survey, and we will follow up via email after the presentation. So a little bit about the Patient-Centered Primary Care Institute. It was launched in 2012 as a public-private partnership between the Oregon Health Authority, the Northwest Health Foundation, and the Oregon Healthcare Quality Corporation. Our goal is to facilitate access to a broad array of technical assistance for practices that are at all stages of transformation through web-based resources like this webinar today, other resources available on our website, and other training programming. We want to build capacity and create alignment to support ongoing transformation and quality improvement in Oregon. We encourage you to visit our website to access resources that are available to the public, including previous recorded webinars. You can also sign up for our email list through the website, and that's how you can stay up to date on what's going on with the Institute, including additional web-based and in-person training opportunities in the future. With that, I'm going to hand things over to Dr. Evan Salino and Don Creech with the Oregon Health Authority to start their presentation. Dr. Salino is a physician and serves as the PCPCH Program Clinical Advisor. And Don, in competition for the longest job title ever, is the PCPCH Program Lead for Recognition, Technical Assistance, and Communications. So thank you for joining us, and take it away.
Thanks a lot to everybody for coming on the webinar. Don, you can go ahead and take it.
Hi, everyone. This is Don Creech. Thanks again for joining us today. So we're just going to really briefly do an overview of the history of the PCPCH program. It was established by House Bill 2009, created by the Oregon legislature. House Bill 2009 started laying some of the foundational groundwork for health system transformation in Oregon. And they created the PCPCH program really with the goal to create access to patient-centered, high-quality care and reduce costs by supporting practice transformation. The program built off the work of the Oregon Health Policy Board, which really urged the PCPCH program to move forward decisively to transform the primary care delivery system. Our program functions that we do today include the PCPCH recognition and the verification site visit process, refinement and evaluation of the PCPCH standards over time, which is what we're going to be talking about today, conducting communication and provider outreach, coordinating across OHA, CCO development, and other health reform initiatives. also to develop technical assistance, which is something that we're doing in partnership with Quality Core and Northwest Health Foundation in terms of the Patient-Centered Primary Care Institute. And lastly, to restructure primary care payment to begin to align with the PCPCH framework. So Oregon's goals for PCPCH are pretty broad but really important. First of all, that all Oregon Health Authority covered lives, so almost 900,000, and will also be growing in 2014 with Medicaid expansion, but that all of those covered lives receive care through a recognized patient-centered primary care home. So this would include Medicaid, public employees, Oregon educators, the high-risk pool, etc. The goal is also that 75% of all Oregonians have access to quality care through a PCPCH by 2015. And as we'll find out in a couple of slides, we're really well on the way towards accomplishing that goal. And then lastly, to spread to private payers and qualified health plans through the exchange. So with that charge, the PCPCH program convened a Standards Advisory Committee in 2009 and 2010. It was really composed of multiple stakeholders and experts in the medical home model. And these folks got together during 7 public meetings to really decide what the Oregon model for a primary care home should look like. They reviewed past work, other state, federal, and private efforts, and really decided that they wanted to develop their own Oregon-specific model. The group produced 3 principal products, which are the core attributes, the standards, the measures, and the guiding principles for implementation. We reconvened a second group in fall 2010 with a focus on pediatric adolescent populations. And then when the standards and measures, the initial standards and measures were finalized in October 2011, the model was launched and we began accepting applications. The original Standards Advisory Committee developed a really comprehensive set of standards, and it was always envisioned that only a subset of those standards that were sort of determined to be most feasible for implementation would be first launched, and that later additional standards in the model would be refined. That was always the intention. So what you see in the fall 2011 standards is really a subset of the overall standards that the committee envisioned. So what you see here is really what they defined as the core attributes of a primary care home. So everything that you see in the model is really organized under these 6 core attributes that could describe a primary care home, being patient and family centered, coordinated, providing comprehensive whole person care that's continuous over time, built on relationships, care that's accessible, and also care that's accountable and high quality. The Standards Advisory Committee also felt it was important to explain the PCPCH model in patient-centered language. And so what you see here is what they developed to kind of explain to consumers and to the public what the value is of this type of care. And that's something that we really, in the program, take very seriously. Everything that we do is always guided, and we're always thinking about things from the patient perspective. What does this look like, or what does this feel like if you are a patient in a primary care home? The committee also developed the idea of having different levels of primary care homeness. They really felt that transformation was on a continuum. They wanted to encourage clinics to advance from maybe a more basic primary care home to an advanced primary care home. So this is what you see in the model today, where there's 3 different levels, with Tier 3 really envisioned to be a very advanced and robust primary care home. So where are we today? We are thrilled to report that we have over 380 recognized primary care homes in Oregon. We believe that this number is getting close to half of all the eligible clinics in Oregon that could be recognized. So we are thrilled that the program has had such a good turnout, and we really appreciate the opportunity to partner with the primary care delivery system in terms of providing better health and better care for their patients. And if you haven't had a chance, we are creating a lot of success stories on our website to highlight how different types of clinics across Oregon are achieving the PCPCH model. And a lot of those stories are framed from the patient perspective. So what does that care look like for them, and how has that care affected their health? So if you haven't had a chance, please check out our website, success stories. They're really neat. So also on our website, we have a very cool GIS-enabled interactive map of all the primary care homes to kind of give you an idea of the distribution. Obviously, they look a little bit like the population clusters in Oregon, but we are very much looking forward to having more recognized primary care homes out in the eastern Oregon area. And we actually traveled out to Hermiston last month to talk with some folks out there. And I'm going to hand it over to Dr. Salino. He was actually part of the Standards Advisory Committee that was reconvened in 2012. So the idea was that now that the model has been implemented, what are the next stages of the model? And so Dr. Salino is going to talk a little bit about the 2012 committee.
Yeah, thanks, Dawn. So yeah, this was again, the Standards Advisory Committee is really a multidisciplinary group of folks from the medical world, internal medicine, family medicine, pediatrics, behavioral mental health, pharmacy was an important part this time around, hospitals, health plans. Really a group of folks, it was really neat to see them sitting around and talking about, okay, so how can we make care better? What are the specifics about what's the evidence show? And really trying to make this model work for clinics all across Oregon. So it was actually a really great group to see. They had several, I think there were half a dozen or so meetings in the late summer, early fall that were public meetings. And the goals of the committee were, as listed on this slide, were, the first was to expand the model. As Dawn talked about, the original Standards Advisory Committee had really a whole variety of things that they felt fit into the model, but when we were starting out, we wanted to start somewhere and then expand the model from there. And so the effort was really to expand this model as the next step in this stepwise implementation process that fits with the delivery system transformation we're trying to do here in Oregon. The second goal was to rely on the foundations of evidence whenever that is possible. Of course, as we're going forward, as we learn more about whether or not interventions work, how well they work or don't work, we want our model of care, this clinical model of care that defines what high quality, high value primary care is, we want that to reflect the evidence as much as possible. The third goal was to really increase the rigor of the model so that primary care clinics at different points of transformation, clinics of different sizes with different patient populations and different geographic regions of Oregon can be incentivized to essentially continue along this transformation process of starting somewhere and moving up the ladder of providing more robust, more comprehensive primary care. The next goal was focusing on the standards and measures, really trying to recognize that the technical specifications would be part of that, but trying to create the best standards and measures possible to get the nuts and bolts about how, again, that definition of what good quality care is. And then the last piece was minimizing the burden of reporting, and this is important, obviously, to any of us that do work in the primary care world, trying to minimize the amount of material that clinics need to print up and send in and report and things like that, understanding that, as well, it is important for clinics to be doing some level of analysis of data and things like that, but really trying to minimize that burden of reporting was important. And the final Standards Advisory Committee report is available online on our website, and I think there's a live link once these slides are available as well. And then I'll give it back to Dawn to continue on about explaining how this process works with the 2013 standards.
Yeah, so just to give you an idea of sort of the timeline, so in October 2012, the Standards Advisory Committee finished their meetings. The final Standards Advisory Committee report was compiled, which is available now. The PCPCH program at this point has submitted our proposed changes to our program rules. So these are the administrative rules that guide our program. Those are currently, our proposed changes are currently open for public comment, which is where we're at now. Those close June 14th for public comment. And then after the public comment, the program takes into consideration the comments that we've received, and our program roles are made permanent. We expect that then all final criteria and the technical specifications for each of the measures will be available in July, and we're working hard to make that happen. So with that, it's important to note that this webinar content is based on the draft proposed program rules, including the proposed standards and measures. And so given that we are in a public comment period, it's really important to note that some of these things may change. And I am going to hand it back to Dr. Selena.
Excellent. Thanks, Dawn. So let's get into the meat of this, which is really trying to get at what you need to know about these 2013 PCPCH standards for recognition. And so just to start out, first of all, things to really keep in mind. Again, if you look at the Standards Advisory Committee report, there are a lot of different standards, and really, when you look at them and look at the details of them, you'll see that they really fit with a lot of the other things that are going on in Oregon and really in the nation. So the whole meaningful use piece, there are several standards that really hit on those sorts of things. Those of you who are involved with Comprehensive Primary Care Initiative, this multi-payer primary care initiative, some of the standards really hit on some of the things that you're doing specifically for that program. When you look at the CCO metrics, so the things that the CCOs are going to be measured, that coordinated care organizations are going to be measured by health outcomes, utilization, certain screening measures, things like that. When you see those things, you'll see alignment with some of these PCPCH standards and measures. That is on purpose. So the idea really is to not have us all running a bunch of different directions, but actually to coordinate our actions, coordinate this transformation effort as much as possible, and again, try and get things that are good things moving in the right direction so that they're actually useful and not just administrative functions or checking boxes, that sort of thing. Another thing to keep in mind is, as Dawn pointed out, the details of exactly examples, what meets and doesn't meet the different standards and measures, will be clarified in the technical specifications. As noted, we're in this public comment period. The TA guidelines will be out on the web as soon as we can make them available, and that's where the details will be. It is really important that for you to read over those technical guidelines, because even if you were meeting certain standards or measures under the 2011 PCPCH standards and measures, some of the technical specifications may have changed. We've, as we go out and see clinics doing this work, as we do site visits, as we learn more, that's informing the program and informing, the details and really the clarification that's provided in the technical specifications. So definitely read over things, make sure you're still meeting the things that you think you're meeting, even if you've met them in 2011.
Yeah, so in terms of the timeline and what this means for you, we are proposing that the revised criteria become effective on October 1st, 2013. What this means is that any clinic that is not yet recognized has up until close of business September 30th, 2013 to apply under the 2011 standards. Any clinic that is applying for the first time or submitting an annual renewal application on or after October 1st will attest to the new 2013 standards. And if you are a clinic that is currently recognized as a Tier 1 or a Tier 2, you may submit a 6-month tier adjustment application under the 2011 standards if it has been at least 6 months since your last effective date of recognition and your clinic now meets the criteria to be recognized at a higher tier. If your clinic is already recognized, and many of the clinics have an October 1st recognition date, so if you fall in that category, you will be applying using the 2013 standards. We do ask that you wait until October 1, 2013 to submit your application online, and that will be important because the 2011 standards will be available on the online application system up until September 30th, and then on October 1, the new standards will go into effect in the system. And so then you'll have 30 days to prepare and submit your application online without having any kind of lapse in your recognition status. Any clinics with other recognition dates that are after October 1 will apply under the 2013 standards when they are due to submit their annual renewal applications. And I know that this is a lot of information, and so if you have any questions about what this means for your individual clinic, please contact us, and we'd be happy to assist you.
Okay, so let's get into some of the details about what's in the new 2013 PCPCH standards and measures. First of all, to start out, there are still 10 must-pass standards that all clinics must meet in order to be recognized at any level. 2 of these must-pass standards are different, so 2 of them have changed, but there are still 10 just like there were in 2011. There are a larger number of points available and a larger number of standards and measures that are optional. So it's really sort of a menu of options to look at and decide, what you want to work on, what you want to try and improve on, and what you may be meeting. There are more points on the table. But the levels, tier levels, are still essentially the same percentages, and we'll see that in just a second. The other important point, which is really the same as the 2011 standards, is it's the total number of points accumulated that determines your clinic's overall tier of PCPCH recognition. So, for example, again, clinics that you don't have to meet all Tier 3 level measures, for example, to be a Tier 3 PCPCH. It's your total number of points overall from the measures that you meet that have to be above that Tier 3 threshold. So here's the tier levels with the point amounts. And there's the Tier 1, Tier 2, Tier 3. Again, there are more total points available when you look at that and compare to the 2011 standards, but there's the same relative distribution for determining the overall tier level. So really, again, the critical point to take home is this is going to offer you a menu of options to get credit for doing things that your clinic is already doing or that you want to do or areas that you want to work on. This is a list of the 10 must-pass requirements, and as you'll see, there's several that are unchanged. There's several that are revised, and again, so you can look at the Standards Advisory Committee report and the technical specifications, and they're available to see those details. But there's a new standard, which is 6D0, which we'll talk about in a sec as well. Okay. So going through some of those changes in a little more detail. One of the changes is in the whole person comprehensive whole person care core attribute standard 3B0, which is really that definition of that whole person comprehensive care that a primary care home gives. So in that it talks about offering acute care and chronic care and offering preventive services and health promotion services. And added to this is really a critical piece, which is called out several times in these new standards and measures, which is the addition of managing prescription services over time. And that management over time is really critical, and obviously all of us would recognize the importance of prescription and pharmaceutical management in comprehensive whole person care. In 3C0, which is the mental health and behavioral health standard, basically there it talks about assessing people for mental health issues, substance abuse issues, and developmental issues. And in the original 2011 standards and measures, the word "or" was in there. So it said something like mental health, substance abuse, or developmental screening is what a clinic had to do. When the intent really was, that you'd be doing screening that's appropriate for your population, and that if you're taking care of all ages, you'd be doing developmental screening for kids, and you'd be doing, depression screening for adolescents and adults, and substance abuse screening for those two groups as well. And so the intent was "and," but some people misunderstood that intent, even though it was really laid out in the technical specifications. So that "and" is put in specifically into 3C0, so doing all of those screening things is important for the populations that you take care of. Another must-pass change is in Standard 4A, which is the attribution of the PCP, a primary care clinician, with the patient, and so we're no longer requiring data submission for that standard. And then talking about this new standard that is a must-pass standard 6D0, which is essentially ensuring that the patient's experience and feedback is being assessed in some way. The idea is really that you're surveying, survey meaning a verb, not necessarily a noun, but that you're assessing patients' experience and involving them in trying to make care better. For some people that will mean if they're not doing a CAPS survey, if they're doing some other sort of survey, then they may be doing that. Some folks are having focus groups. We've seen, as I go around and visit clinics, we've seen clinics involve focus groups in designing, the way a new clinic is built. We've seen clinics have on exit when they're sitting there at the front desk or in the waiting room, having them actually fill out some survey about how the front desk is doing. Having some assessment of what the patient experience is, we felt was really so critical to this patient-centered model. The title has patient-centered in it, that it was really important to incorporate that as a must-pass standard. And then another notable change to the must-pass requirements is that standard 4E in the 2011 standards, which was the hospital agreement. That was a must-pass, but it's no longer a must-pass. However, it is obviously a really important thing, that coordination between the primary care clinic and the hospital. It's been really foundational for some clinics in engaging hospitals around that care coordination piece. At this point, it's a Tier 1 measure, which is actually worth now 5 points. So you get some points for having that in place. Some other changes. So we were talking about expansion of the total number of points and the sort of a menu of options, especially in core attribute 2, which in the 2011 model only had one standard. This core attribute has expanded really dramatically. So there are several different standards in there. And these just kind of lay out some of them. The standard 2B, there are 2 different measures that you could meet. One of them is about public reporting, so things like quality corporation reporting or other reporting that you're doing where you're publicly reporting quality information. And then the other measure is essentially how data is used in your primary care home. So is it shared with frontline staff? Is it used to provide sort of quality improvement structure and information and guide quality improvement? Those are different standards, different measures that can be met under Standard 2B. Standard 2C talks about patient and family involvement. So this is a thing that I think most of us sort of struggle with, how best to involve patients in improving care. And it's obviously really critical, and evidence certainly points to how important it is and how really valuable it is when that is incorporated. So there's 3 different measures essentially allowing you to look at how you can engage patients to help make care better. Are they involved with quality improvement efforts, things like that. Standard 2D, which is all focused specifically around quality improvement, is also, there's 3 different tiers, Tier 1, 2, and 3 for that. And it really is assessing, do you have a quality improvement strategy in your clinic that is specific, that has goals, that has measures, that has follow-up? How robust is that quality improvement strategy? And when you look at those different measures, it helps you sort of allow you to structure your thinking about how to build that quality improvement strategy if you don't have it in place, and how to assess it if you do. And then Standard 2E is looking at utilization data. So this is something that obviously some payers are very interested in. Obviously CCOs are very interested in, and it's actually one of their metrics that are being measured on is hospital utilization, overall utilization. So looking outside your own clinic and thinking about, okay, what is the data on our patients in terms of the care that they use, and where are the possible areas of intervention? And if we do intervene, how do we know if we're having success or not? So that's what those this standard and those measures, those 3-tiered measures under that standard, are getting at. And again, that aligns with the work that CCOs and other payers are interested in. In Core Attribute 5, there's also some expanded standards and measures. There's some new measures here that I just want to mention briefly. Under Population Data Management Standard, that's 5A, there is a new measure that essentially is talking about stratifying patients according to health risk. So the folks that are involved in the Comprehensive Primary Care Initiative are doing some of this work But essentially, this is about looking at your patient population and thinking about, okay, who is at the most risk? Who are the top 20 or 25 patients that I worry about all the time in my head and I know are really at high risk of having problems? If I could list those out on a piece of paper and all the other folks in my practice could, how would we manage those folks proactively instead of reactively? Not only doing that, thinking about, okay, who are the people below that level, those folks who have some medical problems, maybe they haven't been in the hospital recently, but they're just about to, sometime in the next couple of years. How do we intervene before they get there? And then sort of go down from there. It really helps you target really limited resources on the folks that are at the highest risk. So this measure is really getting at that process. In Standard 5C, which is about complex care coordination, which has the care planning measure in it, for example, and it talks about care coordination, there's a specific measure that talks about training for care coordination. Training for care coordinators for patients with complex healthcare needs. So we understand that, it's one thing to call somebody a care coordinator, and it's a completely different thing to have really the training that's needed, the motivational interviewing, the assessment skills, the follow-up skills, the goal-setting skills that a care coordinator who is well-trained can provide. And again, as we go out and do site visits, we've seen this really robust complex care coordination model that makes a world of difference for these really at-risk people and keeps them out of the hospital and keeps them healthy and keeps them in their home and that sort of thing. And then we've seen folks really struggling to assess what, if I have a nurse in my clinic, what am I supposed to do to get them to manage complex patients? I don't know. And so really this measure is really getting at providing some of that structure. And there are examples of care coordinator training. We did not call out a specific example in this measure, but for example, the Institute for Healthcare Improvement has a really robust training for care coordinators, just to throw out one example. And then Standard 5F, which is the end-of-life planning standard, there is the standard about providing essentially hospice and end-of-life care management and coordination. And then there's a new standard. The old standard was in the 2011 standards. There's a new standard, new measure, 5F1, which really talks about end-of-life care conversations like advanced directive conversations and management of getting things like the POLST form, the Physician Orders for Life-Sustaining Treatment, getting that into the registry so that it is functional and really, again, best utilized out in the community. So there's a specific standard, specific measure under Standard 5F, the end-of-life planning standard, that is worth 5 points there. There are several standards that essentially are check all that apply standards. There were, I think, 2 examples in the 2011 version that some folks were actually confused about whether or not they could apply or attest to meeting different things. In these specific standards that are listed, 3C, 5C, and 5E, these are check all that apply standards, so you can receive points simultaneously from different tiers on these different standards. Because there are specific things that are measured, that are called out, that are important in these different standards, you can receive up to 25 points in 3C, 30 points in 5C, and 30 points in 5E. So again, look at the details of those things. Some standards that really foster improvement, again, as we're thinking about expanding this model and expanding and fostering healthcare transformation, we really wanted to, the Standards Advisory Committee really wanted to set up some standards that set out the Tier 1 measure as clinic, go ahead and just track something, do something, track some data. And the Tier 2 measures would be, okay, clinic, take that data and improve and show some improvement, show some quality improvement processes that work. And then at the Tier 3 level, meet a benchmark of quality of care or quality measures that shows that you're maintaining that, that quality of care, you're doing that quality improvement and maintaining it over time. So these measures, these 4 measures that are listed, have that example. You'll see that pattern laid out with those 4 measures. Again, the details will be in the technical specifications. In order to demonstrate improvement, the clinic must provide essentially improve a certain amount of time. Improve a certain amount over a certain amount of time. For example, 5% in 6 months. However, as we're launching these standards in October 2013, we don't have a baseline. You all don't have a baseline as you're looking at things yet. So it's difficult to improve on something if you don't have a baseline 6 months in advance of when you're applying. So for this first year, when we launch this new set of standards, the plan is to accept the first year an improvement plan. So that lays out which specific measures you want to improve, how you're going to improve, and over what period of time you're going to improve, and what you're going to measure to show that improvement. The details, again, of what will be needed will be laid out in the technical specifications, but that's important to understand as you're thinking about this and thinking about how could we improve if we're not sure what we're measuring yet. Again, we have heard feedback about that and have taken that into consideration. Just a few more to go. A couple of changes specifically in Standard 1A, the in-person access standard. So this obviously is really important, again, as we're thinking about the first step to getting any kind of care is improving access. And so when we're assessing access at that first level, that Tier 1 level, we're still accepting essentially any type of survey to assess in-person access. So that can be whatever, if you're working with a vendor or you've designed a survey that is done and you're trying to assess that access, that's acceptable for that Tier 1 level. Same as the 2011 standards. For the Tier 2 or Tier 3 measures, a CAHPS-based survey has to be used, a CAHPS survey, and the clinic has to submit that survey data, okay? At the Tier 2 level, you don't have to, at the Tier 3 level specifically to meet benchmarks, because the benchmarks are established based on specific scientific sampling methodology. In order to meet those benchmarks, it's going to be important for you to look at that technical assistance guide and think about, if you're trying to meet those benchmarks or attest to meeting those benchmarks, that you are following that scientific sampling methodology so that you know whether or not your data is actually applicable or comparable to those benchmarks. On Standard 2A, and this is the second to last one we'll go through, on Standard 2A, which is all about performance and clinical quality, and again is in that the quality improvement core attribute essentially is the accountability core attribute. For Standard 2A, you are required to submit data for that, so your core and menu measures of clinical measures that are NQF measures, you are required to submit data. That's a change from the 2011 standards, which for that basic must-pass level did not require data submission. Now it does. And the other change to that Standard 2A is that those core and menu measures, when you look at those, there's some pediatric ones, there's some adult ones. There's ones that are probably, as you look at them, ideally appropriate to your clinic population. So when you're picking things to improve on as targets for improvement, when we're thinking about this as accountability core attribute, and we want to be accountable to the care for the population that we take care of, ideally we want the measures to be reflective of the population that we do take care of. There are some really specific examples that are really required. So for example, I am a family physician, so when I take care of children and adults, it's really necessary, required essentially, that I'm going to be reporting on at least one of the pediatric focused quality measures, because a big subsection of my patients are pediatric. I'm also going to be reporting on some adult measures because, again, that reflects my patient population. What I can't do is say I'm going to cherry pick the easiest 3 pediatric measures or the easiest 3 adult measures that I can pick and have it not be reflective of my patient population. You really want this to be, again, a robust accountability core attribute, and that's what this standard reflects. So finally, a few specific changes to Standard 3C, the mental health, substance abuse, and developmental services. The first one I already mentioned, which is the change of an or word to the and word, which is in bold on this slide. And again, the idea is that you're taking care of your whole patient population. This is a clinical model of care, a quality model of care for your entire patient population. So you should be doing mental health screening, substance abuse screening, and developmental screening if you take care of pediatric populations. That developmental piece is critical. Screening, and again, this is something that we found as we go to site visits. It can be confusing for folks to think about what does screening mean, how to use different standardized tools or not. Screening, just as a definition again, means that you're screening all your patients or some group of your patients, okay? So you're screening all your patients. Screening is not triggered by symptoms. If a patient has symptoms and they say, "Doc, I'm pretty depressed," and you use a PHQ-9 as a tool, you're using it as a diagnostic tool, not a screening tool. A screening tool means, again, just like you screen folks for lipids at a certain age, that means at a certain age you're thinking about, like in adolescence, screening for depression, for example. The other thing that screening means is that you are using standardized tools. So it's important to think about using things that work, that we know work based on evidence. So examples like the PHQ-2 or PHQ-9, the SBIRD, which is a substance abuse screening, the MCHAT and ASQ, the ages and stages questionnaires, which are autism and developmental screening tools, respectively, for pediatric populations. Those things are available. They're out there. Some of you, a lot of you probably know about them. They're important to use to know, again, that you're using tools that work. Again, the next bullet essentially hits at that top bullet and things that I've already hit on, which is that you should be screening and doing things for your entire patient population. And finally, for that Tier 3 measure on 3C, if you are attesting to 3C, you do have to have a co-located, integrated behavioral mental health provider at the site, at the PCPCH site. The one exception to that would be rural, or could be rural telepsychiatry. Essentially, if you look at that standard, that measure, and the specifics of that in the technical specifications, you can see whether or not your clinic would be meeting that measure. And that'll do it. I'll hand it back to Dawn.
All right, just really quick, one more slide, and then we'll get to your questions. We just want you to know that there's a number of resources and technical assistance that will be available about the 2013 standards. We're working on a sort of a quick reference guide that lists out all the standards and measures, and that will be available online this week. It will also have sort of a column that indicates whether or not the measure is unchanged, whether it's been revised since the 2011 model, or whether it's new to the 2013 model. And again, that'll be available on our website this week. We are working on very, very cool online learning modules that are going to be available in summer 2013 after the standards are finalized. And they'll be available on the Institute website. We wanted to point out that the PCPCI website is already set up to search for resources and tools based on the 2013 standards. So if you go to the website and there's actual drop-down menus, you can search by a number of different things. And one of the things that you can search by is actually set up to search by the 2013 standards. And there's a number of resources available, and it's growing every day. If you have ideas for resources, please get in contact with Kate Elliott. If you have a resource that you think is really great that you would like to share with the primary care community, please get in touch and let us know. We're adding tools and resources to the website all the time. The webinars that the Institute is conducting monthly and sometimes a couple of months, those are all recorded and available online. All the past webinars are online. So if you're unable to make it during a particular time, you can always watch the webinars on a Friday night with a bowl of popcorn. They're available to you. Also, PCPCH program staff is available. Please contact us anytime, and our website is a wealth of resources as well. And with that, we're going to transition to the question and answer period.
So this is Kate again. As a quick reminder, I see some of you are on top of this already, but you can submit your questions via the question pane on the right-hand side of your screen. If you'll give us just 1 second, we're going to sort through a couple of the questions we've received already, and then we will jump back on the line and begin answering those. Okay, we're going to go ahead and start reading some of your questions. The first one, I'm just going to go ahead and read. It's about the quality improvement measures. Since it's the first year and there are no baseline, are clinics still able to attest to Tier 3? And this person asking this question was specifically referring to 1A, 2A, 2E, and 4B. So Evan, can you speak to that?
Yeah, so Tier 3 is the benchmark level. So if there are benchmarks set for the specific core menu set measures or the CAP surveys, whatever, when there are benchmarks set and you meet those benchmarks, yes, you can meet the Tier 3 level.
It looks like we have another question just related to scoring. And I think what the person asking is, looking at the standards and measures so far, how do we tally where we are? And I thought we were able to count points for each metric we meet across multiple parts of the same standard. Can you speak to that related to the scoring?
So your tier level is based on your total number of standards, total number of measures that you meet. So if you go through each core attribute, each of the 6 core attributes, all the different standards and each of the different measures, and you tally the number of measures that you meet. Now there are certain measures, and I put them out on a slide. I'll go back to it here, which are check all that apply standards. So 3C, 5C, and 5E, where you can meet the different tiers and you get all of those points. The rest of the standards have, you would meet at a certain tier level, maybe Tier 2, Tier 1, Tier 3, whatever, for that standard. But these specific standards, 3C, 5C, and 5E, are worth multiple points because you can meet at different tier levels and get credit for all of those points. But your overall tier level for your clinic is based on the total number of points when you add up all those things that you meet.
Okay. Then we had a question related to NCQA PCMH recognition. Is there an option in the new standards to utilize this recognition, plus a shorter list for the Oregon requirement? If so, are the additional requirements noted in the new standard document?
We have looked into that, and there's actually going to be no change in what your requirements are if your clinic is already NCQA PCMH recognized. So you will have the option to essentially skip over some requirements and have a shorter list of requirements that you attest to. It's actually going to be the exact same as it was in the 2011 model. And feel free to contact me if you have any questions about that.
Okay. All right. You can keep sending in your questions. We did get one about how to submit a public comment, where someone goes to do that and how they can do that.
Yeah, so public comment does need to be submitted to Zari Haverty, who is our rules coordinator in the Office for Health Policy and Research. And after the webinar, we can make sure to get you her email address. If you do have official public comment that you want to submit and have be part of the public record, it does need to be submitted to Zari. If you just have informal sort of questions and comments and you'd like to talk to one of the PCPCH staff, you're welcome to contact us.
So really quickly to follow, just as a practical matter, we'll make sure anyone who asked about public comment that you get that contact information that John just referred to in an email message after the presentation today. So if you have asked a question related to that, I'll make sure that you get that. There was a question here about the measure for Measure 1C, same-day access. Does offering urgent care after hours count?
So that's a really good question. What I would say is this is not changed from the 2011 standards, which is essentially the important thing is that you're trying to improve access to care, and that's access to all the care that you provide. The intent of the measure was to expand access not only to urgent care, but also to routine care for folks who are, for example, working business hours, have kids in school, and are trying to shop, trying to work in a doctor's appointment is really difficult for them. But expanding hours and allowing access to not just urgent care, but to routine care as well, preventive care if necessary as well, is really what the intent of that measure is about.
Okay. So the questions are rolling in at this point. We have one related to clarifying the information about reattestation and the standards version for practices that are due for their annual resubmission by the date that was mentioned in the presentation. What are eligible for submitting an update every 6 months? Can they submit early? And can that be the current standards, not the new ones?
Yeah, so if a clinic is recognized currently as a Tier 1 or Tier 2, and they are eligible to submit a 6-month peer adjustment application. So that means it does have to be at least 6 months since their last effective date of recognition, and the clinic does need to actually meet the criteria to be considered for a higher tier level. They can submit a 6-month peer adjustment application now, and they would be attesting to the 2011 standards, and that would be up until September 30th of this year. On October 1, the new standards will launch. Any clinic that's already a Tier 3 is not eligible to submit a 6-month peer adjustment application because they are already a Tier 3. And any clinic that has an effective date of recognition of October 1, 2013 or later will be required to attest to the 2013 model when they reapply, and we do ask that they wait to submit their annual application until October 1, 2013, and we'll actually be sending individual emails out to those clinics with more information.
Okay. So we're getting a lot of varied questions, so apologies for the bouncing around, but one of the other questions we got was who sets the quality benchmarks, and I think Dr. Salino is going to speak to that.
Yeah, so the menu and core clinical benchmarks are set by the National Quality Forum, NQF measures is what we call them for short. So that's a national group, so they're not set specifically by the program.
Sorry, we're sorting through questions here.
And then the CAP benchmarks are set by HRSA, which again, federal agency. So those benchmarks are set by them. And those are used, CAP is used as you're aware, so again, the folks in the Comprehensive Primary Care Initiative are using that through with Medicare, and some payers as well are using it. So.
All right, another question for Dr. Salino. 3E says track unique number of patients receiving outreach. We attest to this, but that means you must have a reporting system to know, or does a policy or a procedure suffice?
Right. So what we're really looking at is functionality. So if you're tracking, interactions with patients, or if that's what you're talking about, yeah, we're going to want to see the functionality of that. You are going to need some sort of system to know whether or not you're doing a good job. It can't be, again, a policy is one thing, and the implementation of that policy is really what we are looking at when we do a site visit as well. And again, that's the functionality. So you do need to have some sort of assessment structure to see whether or not you're doing a good job or not, and to know whether or not you need to improve on that.
Okay, so I think there's a question related to renewal. I thought renewal was every 3 years. Did I misunderstand, or is the renewal process changed to be annual?
Yeah, so sorry if there's any confusion about that. I believe there was actually a misprint in the 2011 implementation guide that did say 3 years. But in our permanent program rules that have been in effect since October 2011, it does require that every clinic submit a renewal application annually, reattesting and also providing new data with their application. Also, when clinics are recognized, they get a letter, and that also states that the clinic does have to submit an annual renewal application. We also send out reminder emails to folks to let them know that they have an upcoming renewal application that's due.
Okay, we're sorting through some of the questions that are coming in. Just give us a quick second here.
I can give it a shot.
Okay, so I think we had a question related to Tier 3 for Standard 2D. Is that? Do you want to remind everyone what maybe that standard is? And then there was a question about explaining Tier 3 for Standard 2D.
Right. So Standard 2D is the quality improvement standard, and there are 3 different tiers under that standard. So the first tier is essentially using data to identify opportunities for improvement and acting to try and improve. That's the Tier 1 standard. The Tier 2 standard, I'm sorry, Tier 1 measure. The Tier 2 measure is that the PCPCH utilizes improvement teams that are multidisciplinary, that meet regularly to review information that is actionable related to improvement projects, and they actually document their progress. So that's pretty specific. That's a pretty robust quality improvement structure. Okay, so that's Tier 2. Tier 3 is even more robust. So you're implementing that clinic-wide improvement strategy with those performance goals. But those performance goals are not just your own goals, but also are derived from patient feedback that involve publicly reported measures, so sharing information with the public about how you're doing, and as well as areas for clinical and operational improvement. So again, not just like let's improve diabetes management, but let's improve the care generally that we're giving in the clinic-wise, operationally-wise. So it's a much more robust level, essentially. That strategy includes that quality improvement methodology, that there are multiple projects that are going on, and that there are feedback loops of information so that a practice knows how they're doing. Again, it really describes a much more robust quality improvement initiative that is multifunctional across the entire clinic, operational, clinical. That's really the difference between the Tier 2 and the Tier 3 measures.
And then it looks like we have a question about whether the standards are set to change any time in the future. I think Dawn was going to speak to that more generally.
So obviously this is a big update to the model, and the program will be relying on feedback both from the Standards Advisory Committee that makes recommendations to the program, as well as other stakeholder input on future revisions of the model. But the idea is that it would evolve. I doubt that that's going to be 1 year from now. We've had 2 years almost with this last model, so I would imagine it would at least be that long. But again, we're going to be relying on a lot of feedback from our stakeholders and also what we're seeing from our site visits to determine whether or not the model needs refined further.
Okay, so we have about 3 minutes left, so if you have any burning questions, do get them in. And like I said, I know we haven't gotten to all the questions that we're getting, so we will follow up via email on the rest. But there was one that we're directing to Dr. Salino. Can you provide more definition for ambulatory sensitive utilization, or will this be described at length in the TA guide?
So yes and yes. So the ambulatory sensitive utilization, the measures are essentially being finalized by CMS. So the measure itself, there are, again, 3 tiers to this standard, this ambulatory sensitive utilization standard, and the details about essentially what that means, about what ambulatory sensitive care means, are going to be in the technical specifications. Basically, there are different categories. One is the ambulatory sensitive condition admission to the hospital, so the number of admissions to the hospital per 100,000, for example. Another example of utilization would be follow-up care after transition, so folks that are hospitalized and moving to a skilled nursing facility or to the clinic having specific follow-up. Hospitalization rates for folks with mental illness, and then all-cause readmission rates, which again, readmission to the hospital, as you all are, I'm sure, aware, is a big focus of improvement, of trying to improve. So those are kind of the basic categories, but the details will be laid out in the technical specifications.
Okay, so in the interest of making sure everyone wraps up their lunchtime webinar activity on time, we're going to take one last question, and that is whether or not you anticipate many clinics will lose their tier levels because of how robust these requirements are in comparison to 2011. And Dawn said she was able to speak a little bit to that. Yeah, so certainly no one's intention is that people would lose their tier level. The intention is really that the model continues to evolve and change to the growing evidence base and also to the growing needs of our state and aligning with other efforts. And the idea is really to expand on our current model, make more options available for clinics to get credit for things that are based on evidence and that are going to provide better care to their patients, and that the tiers provide really a roadmap. So, you know, the idea is not every Tier 3 has finished improving the care that they could provide at the clinic. And so, given that, we want the Tier 3s to really be, and the Standards Advisory Committee felt it was really important that the Tier 3 really be a very, very robust type of primary care home that's been implementing multiple quality improvement initiatives for a number of years. So, you know, we want to see clinics move along that continuum, and we don't want clinics to say, well, I'm a Tier 3, I've done all I need to do. And so that's really the idea behind the model. One thing I do want to point out is that clinics do have the ability to submit 6-month tier adjustment applications. So, say, for example, you do attest to the 2013 standards, you potentially do move down to a Tier 2. Well, guess what? You can implement a few things and submit a 6-month tier adjustment application after 6 months to get back to that Tier 3 level. So that's always an option for you to keep in mind.
And I just wanted to add that, you know, what we did not talk about today was the standards and measures that are not changing. And there are, you know, significant numbers that, again, if you attest to the 2011 version, that you can still do. And again, the levels at for the tiers for the total number of points are the same as the 2011 standards. So so although this is a more robust model, when you look at all of the standards and measures put together, again, this is really a menu of options, and hopefully, as Dawn pointed out, will foster improvement and help folks move in the right direction and establish some pathway about how to do so.
Okay. So we're right a couple minutes over even, so thank you to everyone for attending today. Everyone who registered will actually get a link to a recorded version of this presentation, as well as a link to the Institute website that has a PDF version of the slides, all of which will be posted to the website by 5 today. You'll receive the email with the links tomorrow. If you just can't wait, you're welcome to take a look at those this evening. Thanks again for participating, and again, please complete the survey after the presentation's over today and let us know what you thought of today's presentation and leave us any additional questions. Thank you.